So let's talk about the differences between atopic dermatitis, contact dermatitis, and psoriasis. Let's start with atopic dermatitis. What is atopic dermatitis?
Allergic.
So allergic, so it's part of that atopy, that march of atopy. What else is in the atopy family?
Allergic rhinitis, asthma,
Eczema.
Fantastic. So allergic rhinitis, atopic dermatitis, and asthma, right? Usually, do you know what age it presents? So if somebody's doing the atopy march, do you know what they usually present with first?
Probably a rash.
And so they usually present with atopic dermatitis, and then they may progress to allergic rhinitis, and then they may progress to asthma. People don't always do the atopic march, but in families where you have a really strong history of atopy, that's usually what we see. Describe the rash of atopic dermatitis for me. And you'll notice I'm using the term atopic dermatitis because that's the medical term, right? Eczema is actually a descriptor. So you can talk about a lesion being eczematous, but really when we're putting in our medical diagnosis, we should use the term atopic dermatitis. So what is an eczematous rash? What does that mean?
so maculopapular with like
Erythema. Pruritus.
flakiness.
So maculopapular, what's a macule?
It's a flat lesion under 1 centimeter.
Fantastic. A flat lesion under a centimeter. What is a papule?
Papule is larger, but it's a flat lesion larger than 1 centimeter.
It's a raised lesion.
Yeah.
So it's a raised lesion that's under 1 centimeter. What is a large macule called? So a flat lesion that is
Plaque.
larger than 1 centimeter.
Plaque. Right? Patch.
It's a patch.
It's
It's a patch. What is a large papule called? So it's raised, but it's larger than a centimeter. That's a plaque. Absolutely. That's a plaque.
Right.
So if we're using any of those descriptors to describe atopic dermatitis, what would you guys, if you had to choose just one of those, what would you think it most commonly is?
I would say a patch.
Yeah, it's usually a patch. So you said macule and you said patch, which is smaller and then bigger, right? So usually they're larger than a centimeter, and usually they're pretty flat lesions. What else can we use to describe those lesions?
severely pruritic.
So pruritic, although we can't see
Oh,
that
right.
on exam, but you're right. That's usually what the patient's describing.
Erythematous is
So
red.
they may be erythematous, absolutely. What else? What is classic for eczema? You look at somebody and you go, oh my gosh, you absolutely have eczema.
Dry skin.
Dry, they're really dry. So dry, scaly patches, pretty classic for atopic dermatitis. And that's a descriptor when we say eczematous. We're talking about a dry, scaly patch. And usually you can see evidence of excoriation, so you can see evidence that they have been very pruritic. Where are the classic places for atopic dermatitis?
On the folds, on your elbows, on your knees.
Fantastic. So the flexor surfaces of your upper extremities and your lower extremities, so behind the knees, or right in the antecubital areas. Beautiful. What usually happens first, the itch or the rash with atopic dermatitis?
The itch that rashes.
Exactly. It's described as the itch that rashes. So when you're treating atopic dermatitis, one of the first things you need to do is control that itch, control the pruritus. How can we control the pruritus?
Corticosteroid topical.
Sure, so topical corticosteroids will help, especially once the rash has already appeared. That's going to help decrease the inflammation. What else? Benadryl, totally, diphenhydramine, right? So giving some antihistamines. So even before they develop the rash, they're going to feel really itchy and they're going to scratch, and that's going to cause the rash to come out. The rash is like a cyclical effect, so we want to break that cycle. What else is very important for atopic dermatitis, considering that it's a very dry rash? How do we treat it? Totally. We need to keep it really well moisturized. So Vaseline is probably one of the cheapest, the least expensive, very good topical emollients, so really thick coverage. You can do wet to dry dressings. So in patients that have really severe eczema over most of their body, atopic dermatitis, you can have them take a bath, take a set of cotton pajamas, long sleeve cotton pajamas, soak them in water and wring them out, but have them still be damp. Put that on the child and then put dry pajamas on top, and that's going to help trap in that moisture. So it's going to help keep their skin really well moisturized. because it's a rash of dryness, where do babies not get eczema? So if you're looking at a child who has a lot of atopic dermatitis, it will not be in one area because that area almost always stays moist. The diaper area, absolutely. And that's in contrast to psoriasis. Because psoriasis can look similar. What's the classic lesion of psoriasis look like?
Salmon scales.
Salmon scales, and if we're talking about a macule, a papule, a plaque, or a patch.
It's a plaque.
It's a plaque, absolutely. It's hyperkeratotic, right? So it's raised. So it's a larger, raised, salmon-colored lesion. It may also be scaly. If you peel off some of the scales, what might you see?
Pinpoint bleeding.
Pinpoint bleeding.
Fantastic pinpoint bleeding. What's that called?
A niche.
Oh
Oh my gosh.
No.
Auspitz?
Auspitz spots.
There you
Yes,
go.
absolutely. And that's pretty classic for psoriasis. Where do we see psoriasis? What parts of the body?
It's gonna be on extensor
On the dorsal
surfaces.
surface?
Yeah.
Your arm?
So the extensor surfaces, so more the elbows, the knees. You can certainly get scalp psoriasis. You can get scalp psoriasis. No, you can just get regular psoriasis in the diaper area or in the genital area. Tends to be much more difficult to treat, right? It's not a problem of it being under moisturized. It's a problem of having hyperkeratosis. Fantastic. And then how does that all contrast with contact dermatitis?
You have an
So contact dermatitis, it would be specific to, like, say there was exposure to nickel or irritants, like chemical cleaners or something
Okay.
like that. It would be at specific regions, so it would be more localized rather than systemic all over.
Fantastic. So it can be more localized based on the area that's been in contact with whatever the person is allergic to or reacting to. You mentioned nickel dermatitis. Where might that happen?
So like
The
around
belt.
the belt area.
Fantastic. Say the parent has recently switched to a new detergent and they think their child is allergic to it. How may the child appear?
itchy.
More itchy on their clothes.
Yeah, absolutely. So anywhere where the clothes have touched them, right? So the patient that I just saw has this little tiny patch of irritation, and mom was saying, "Oh, I think it's probably due to the new detergent that we're using," and I was saying, "Probably not, because I bet you more of her skin has touched the spot where that detergent is on our clothes than just that one little spot." So usually it'll be much more widespread. What does contact dermatitis usually look like?
Erythematous.
Uh-huh.
I would say macule or
Going into patches
yeah.
with a little bit of flakiness.
Yeah, and sometimes you can see some papules too, right? Depending on the type and the exposure of contact dermatitis, it can look like a lot of that. Oftentimes you can see excoriation in those areas, so scratches, superficial scratches as well, because it may be pretty itchy. Tell me about a specific contact dermatitis caused by something like, so if somebody has these linear,
Poison ivy.
yeah, totally. Thank you for reading my mind. So if you have poison oak or poison ivy, it may be linear and they may be little tiny papules, right? All in a line, very itchy, very erythematous. And that would make you think of contact dermatitis. How do we treat all of these?
Avoid the irritant.
Fantastic. So avoid the irritant in contact dermatitis. If the patient has atopy, and they have atopic dermatitis, you want to help them to avoid whatever they're allergic to as well. Psoriasis, there's not a lot to avoid. How else do we treat them?
You can use a low dose or low percentage triamcinolone cream. For
Yeah,
contact dermatitis.
absolutely. So really with all of them, we're using topical corticosteroids, right? That's kind of the nice thing about dermatology is we put hydrocortisone on everything. We usually start with hydrocortisone. Do you know what the over-the-counter percentage of hydrocortisone is?
0.01%.
That's for triamcinolone.
That's for triamcinolone. It's 1%. So hydrocortisone 1% is what you can get over the counter. Do you know what the prescription strength hydrocortisone is?
2.5%.
Fantastic, 2.5%. So it's 2.5 times stronger. So that's usually the next route that we'll go. And then from there we'll go to the triamcinolone because the triamcinolone is a little bit more potent. As we're talking about, so we usually still start with the topical corticosteroids, even with psoriasis. But with psoriasis, you can start to get into immune modulators and other types of treatment if you need to. Excellent. Any other questions? Fantastic.